The title of my talk today is Ischemic Stroke and Cerebrovascular Injury, an Adipose Brain-Specific Axis. And this is a study that's been going on for about 12 years and had a lot of twists and turns, and I think has really turned into something quite interesting in the end. And it's primarily been driven by these two folks. This is Ingrid Nielsen at the Karolinska Institute in Stockholm, and then Joe Su at the University of Michigan. They've been the primary drivers of this. So very briefly, I'm going to zip through the early part of this. I hope I don't go too fast. If I do, slow me down. But current treatments for ischemic stroke, there are really only two. There's mechanical thrombectomy, which is suitable for large and medium vessel occlusions and should be given within 24 hours of the onset of stroke. And then there's thrombolytic therapy with TPA. It's the only thing approved in the States, and it should be given within 4.5 hours of stroke onset. And its use is limited by the increased risk of hemorrhagic complications. I'm also going to talk a little bit about metabolic imbalances, obviously. So what about stroke and metabolic syndrome? So patients with diabetes, metabolic syndrome have a worse prognosis. Hyperglycemia is an independent risk factor for poor outcomes. Hyperglycemia significantly increases symptomatic intracerebral hemorrhage following thrombotic therapy. However, extensive clinical trials have shown that acute control of glucose does not improve stroke outcome. So the questions that I'm going to try and address is, why is thrombolysis limited to 4.5 hours when thrombectomy is safe up to 24 hours? Does that suggest that TPA has some other function beyond fibrinolysis? Well, we already know from Z's wonderful talk that it does, and I'm going to try and convince you that perhaps there's even more to the story than that. Why does TPA increase the risk of symptomatic intracerebral hemorrhage? Why do patients with metabolic disturbances have worse outcomes and increased risk of hemorrhage associated with thrombolysis? And if it's not hyperglycemia, then what is it? And what I'm going to try and convince you today is it's not the sugar, it's the fat. So what happens to endothelial cells when they are exposed to environment with a relatively high fatty acid content? So we've taken endothelial cells in culture here, and we've treated them either with high levels of glucose or high levels of free fatty acid, oleic acid in this case, and then look at what happens. The first thing that you'll notice is that when you treat the cells with high fatty acid, you dramatically lower the amount of glucose that the cells are taking up. This is important because endothelial cells are primarily glycolytic in their metabolic parameters. They prefer glucose. Even if you add very high glucose levels in the presence of high fatty acids, you still downregulate the amount of glucose uptake. So putting the endothelial cells in the environment with a high fatty acid negatively regulates glucose uptake. And if you put in very high glucose, you don't significantly change the amount of glucose that's uptake. So it seems to be regulated on the level of the fatty acids. You can also see that the cells are, in fact, taking up these fatty acids because of the staining we've done here with perilipin-2. This is a protein that is associated, it basically forms the outer coat of lipid droplets that are taken up by cells, and it's important for neutral lipid storage in cells. And you can see here in the fatty acid-treated cells, you have a lot of these green perilipin-positive lipid droplets. This is associated with a change in the metabolism of the cells, so we can see a very large increase in the presence of fatty acid of ROS generated by the mitochondria as measured by MitoTracker. The cells are storing a large amount of neutral lipids when they're treated with the high fatty acids. And importantly, this has significant impact on the cellular function, because if you look at the barrier properties of these endothelial cells using endothelial resistance assay, you see that in the presence of the high fatty acids, you not only have sort of mitochondrial stress, but you have a decrease in the barrier properties. So this is what happens in cell culture. We want to know, does any of this have any relevance in vivo? So for that, we've used this diet-induced obesity model of pre-diabetes. You see, put the mice on a high-fat diet, they get quite large, their weight is significantly higher, and we consider them to have a pre-diabetic phenotype because of their fasting glucose levels are significantly elevated over the chow control animals. So I'm going to be talking about high-fat fed or high-fat diet animals throughout the rest of the talk. So we know patients who have diabetes or obesity have worse outcomes in stroke. What about the mice? So we're comparing chow-fed mice to high-fat fed mice. We're using a photothrombotic model of ischemic stroke. This model is very nice. It gets a very reproducible occlusion to the middle cerebral artery, and it allows us to do thrombolysis. So we can actually treat these animals the same way you would treat a patient in the clinic with intravenous TPA. So you get a stroke here 72 hours later. You look at the size of the stroke by infarct volume, and you see that the mice on the high-fat diet have significantly larger strokes. Importantly, they also have a significant increased risk for spontaneous hemorrhage. Now, these animals have not been treated with TPA. They've just been stroked. But nonetheless, they have an increased risk for bleeding, and that is also consistent with what's known in patients who are metabolically challenged. We have significant vascular dysfunction in these animals. You can see within 3 hours after the onset of ischemia, we're getting a lot of secondary thrombosis in the microvasculature. This is occurring around the infarct zone. This is the area of the ischemic penumbra where you still have some collateral flow. But the vessels are clearly not happy because you're getting these microclots. We can also see there's a very significant increase in blood-brain barrier damage in the high-fat fed animals, and the quantitation for the fibrin and the blood-brain barrier damage is shown in the two graphs. What was surprising to us was we also found there was a significant increase in lipid droplets occurring in the microvessels in the ischemic penumbra after stroke. And this was occurring both in lean animals and in high-fat fed animals. So you notice over here, this in the non-ischemic hemisphere, we essentially see no perilipin staining, or very, very little perilipin staining in a lean animal that has not been subject to ischemia. In a high-fat fed animal, even in the absence of ischemia, we actually do start to see some lipid droplet accumulation in the cerebral vessels. But after stroke, in the ischemic penumbra, in these regions here, outside the infarct, you see a significant increase in perilipin staining, indicating lipid droplets accumulating in the vessels within 3 hours after the onset of stroke. We can actually show that these are indeed lipid droplets in the endothelial cells. These are electron micrographs. This is a lumen of a vessel. That's a lipid droplet in the endothelial cell. You can see this is kind of a sick vessel here because even 3 hours later you're getting these white spaces developing. This is cerebral edema that's starting to develop around this vessel. We can quantify the lipid droplets in the endothelial cells from the EM. You see in the absence of a high-fat diet, we don't really see any. In the non-ischemic hemisphere, in the high-fat fed animals, we do start to see some lipid droplet accumulation, even in the absence of ischemia. But in the ischemic hemisphere, you see an increase in both the lean animals and a very significant increase in the high-fat fed animals. And this is associated in the high-fat fed animals with an increase in the mitochondrial area, suggesting that there is mitochondrial swelling going on in these endothelial cells, sort of consistent with what we saw in the cell culture with the mitotracker. The mitochondria in these endothelial cells do not appear to be happy. So this brings me to the next factor I want to talk about, VEGF-b, or I like to think of it as the other VEGF, the sort of poor relative of VEGF-a. VEGF-b was studied for many years as an angiogenic factor. It has no angiogenic activity. But several years ago, Ulf Eriksson, our colleague in Stockholm, in a series of very nice papers in Nature, showed that, in fact, VEGF-b regulates fatty acid flux. In metabolically active tissues, VEGF-b upregulates the expression of vascular fatty acid transporters, resulting in an increase of transendothelial transport of fatty acids across the endothelium into the tissue. The only place that doesn't seem to occur is actually in the adipose. In the visceral adipose, VEGF-b does the opposite. It induces lipolysis of the adipose and the release of free fatty acids into the blood. And you can think of this, I think, as sort of a way of responding to metabolic demand. You have fat stores, your tissues, your muscles, say you're running a marathon or whatever, your tissues are really starved, you're going to start to lipolysis of your fat stores, release those fats into the blood, and that's going to provide a source. That's what we think is sort of the normal function of VEGF-b. So what about, does VEGF-b have any effect on the high-fat fed animals on their systemic metabolism? So for these studies, what we've done is we've taken the chow-fed animals or the high-fat fed animals, and we've treated them a short-term treatment with an inhibitor of VEGF-b. This is a monoclonal antibody that's delivered 3 times over a week, and then you can measure the parameters, lipid parameters and glucose and in blood. I'm not showing it here, but we found short-term treatment with VEGF-b does not normalize glucose in these high-fat animals, so they're still hyperglycemic. But what we do find is that there is a very significant reduction in the non-esterified free fatty acids, the NEFAs, with VEGF-b treatment, or anti-VEGF-b treatment, I should say, in the high-fat fed animals. We don't really see a change in the chow-fed animals. We see a reduction in triglycerides as well, and there was a reduction in VLDL, HDL cholesterol, although that's not completely normalized after a week like the triglycerides and the NEFAs are. So blocking VEGF-b seems to improve the systemic lipid metabolism in these mice. Does this have any effect on the brain? So we know that the high-fat fed animals seem to have, even at baseline, a modest increase in lipid droplets in the endothelial cells in their brain. I showed you that earlier in the slide. Those were in the non-ischemic animals. So we can measure those lipid droplets here by staining the perilipin again in the brain of the high-fat fed animals, either with control treatment or with an antibody to VEGF-b blocking that. And you can see the quantitation here that indeed the high-fat fed animals have an increase in these vascular lipid droplets just at baseline. Remember, there's no stroke here, but treating them with the VEGF-b inhibitor reduces that down to baseline. Interestingly, what we found is that glucose utilization is also affected by being on this high-fat diet. So if you look at the open circles here, this is glucose uptake by using PET analysis in chow-fed mice. And in the gray circles here, what you see is a glucose uptake in the high-fat fed animals. So no injury other than putting these animals on a high-fat diet for 12 weeks, you lower glucose uptake by the brain. You can normalize that essentially by 1 week short-term treatment with a VEGF-b inhibitor, which is also correlates with the reduction in these endothelial lipid droplets. So the questions that we wanted to ask now was, does the metabolic dysregulation lead to worse stroke outcomes due to lipid accumulation in cerebral endothelial cells? And is this a VEGF-b mediated process? So for that, we have chow-fed animals, high-fat fed animals. They're treated, again, for 7 days, 3 doses, prior to giving them a stroke. The animals are stroked with our photothrombotic model, and then 72 hours later, they're analyzed. And what you see here on this, these are the chow-fed animals. You see a certain infarct size. This is very consistent with what we always see. And in fact, even in the chow-fed animals, inhibiting VEGF-b for a week makes the stroke slightly smaller. Again, the strokes are much larger in the high-fat fed animals, and those are normalized, in fact, down to the same level that we see with the VEGF-b treated, anti-VEGF-b treated chow-fed animals. This is also true for the cerebral hemorrhage. This is the cerebral hemorrhage score. Again, you can see it's elevated in the high-fat fed animals, and it's normalized by anti-VEGF-b treatment. So it does seem like VEGF-b seems to be doing something to the stroke size. We can also see the same is true for the blood-brain barrier damage. You can see the quantitation over here. The high-fat fed animals have significant increase in blood-brain barrier damage. It's largely normalized by pretreatment with a VEGF-b inhibitor. Lastly, we can look at the actual lipid droplets. So here the perilipin is stained in green. In the top, what you see here is the endothelial stain, CD31 and perilipin. And then down here, we've just removed the CD31 so you can see the perilipin better. The green shows up better here, but you can see it's co-localized with the vessels. This is a non-ischemic hemisphere. You see very little perilipin. There's one little droplet there. In the chow-fed animals, there is an increase in endothelial lipid droplets just by stroke. Okay, so you might think of that as the ischemia is actually sort of starving these endothelial cells, so they've started to take up lipids even when they're not in the high-fat environment. That is reduced when you treat them with, pre-treat them with a VEGF-b. In the high-fat fed animals, there's way more uptake of these lipid droplets, and that is largely normalized, again, by treatment with the VEGF-b inhibitor. And you can see the quantitation over here. These are the lean animals. These are the high-fat fed animals. So we come back to our questions then. So VEGF-b seems to be able to normalize not only the lipid parameters in the blood with short-term treatment, but it also improves stroke outcome and reduces the lipid droplet uptake. But obviously, someone's not going to come in and say, I'm going to have a stroke next week. Can you give me some VEGF-b inhibitor? So what happens if you treat them acutely? That's one of the questions that we wanted to ask. And then also, does thrombolytic therapy affect lipid accumulation? Remember, thrombolytic therapy raises the risk of bleeding. It can increase the blood-brain barrier damage when given too late. Is this also related to VEGF-b? So is the benefit of VEGF-b inhibition in normalizing the systemic metabolism, or is it a local effect on the cerebral vessels? Okay, those are what we would like to know. So the first question, does acute inhibition of VEGF-b improve outcome? And the answer to that is yes. So in this experiment, what we've done, we've taken high-fat fed animals, we've induced a stroke with our photothrombotic model. 1 hour after the onset of ischemia, we give them a single bolus injection of the VEGF-b inhibitor, and then 5 hours after the onset of ischemia, so a half an hour beyond the recommended window for thrombolysis, we perform thrombolysis with intravenous TPA, and we use doses that are comparable, the rodent version of what you would get in the clinic if you were a human. And what you see here is that acute treatment with anti-VEGF-b antibody in these high-fat fed animals significantly reduces the size of the infarct. Importantly, it dramatically reduces the risk of hemorrhage associated with late thrombolysis. And I don't know if you saw the numbers before, but the late thrombolysis does indeed, in the mice, also increase the risk of intracerebral hemorrhage. And you can see here's a guy who had a pretty nasty bleed right here. Interestingly, in our lean animals, we have very little mortality in the stroke model. This is a relatively mild stroke model, and these animals survive quite well. However, in the high-fat fed animals, there is some mortality. We think that's due, actually, to intracerebral hemorrhage. And what you see here with the VEGF-b is we actually completely normalize the mortality also in these animals. So VEGF-b treatment acutely does indeed seem to help. What about thrombolysis? Does that affect the accumulation of these lipid droplets in the vessel? So here we've stained with perilipin 2 again. This is the high-fat fed animals. Stroke is induced 1 hour after stroke. They get a single bolus injection of the VEGF-b inhibitor. 5 hours later, they are subjected to thrombolysis, and then a half an hour after that, the mice are sacrificed, and we look for lipid accumulation by perilipin staining. What you can see is that indeed the stroke increases perilipin staining. That's in red. Intravenous thrombolysis with TPA significantly increases that over the baseline, and both of those are essentially normalized by a single post-stroke treatment with the VEGF-b inhibitor. And you can see the quantitation over here. A very significant increase in perilipin staining just with thrombolysis. So locally, blocking VEGF-b seems to affect the lipid uptake by the endothelial cells. Does it do anything systemically? This is where I lost the bet, actually, because 1 hour treatment shouldn't do anything to the systemic lipid profile, I wouldn't think. And that's true if you look at the triglycerides. There's no change in the triglycerides. However, what we see in the stroked animals that receive thrombolysis, we see a significant increase in the plasma levels of the non-esterified free fatty acids that is normalized by treatment with the VEGF-b inhibitor. So is this rise that we're seeing with thrombolysis, is that potentially driving some of what we're seeing? So is it in fact potentially a systemic effect of TPA that is driving this change in the brain? So to try and answer that question, we went and looked in the adipose itself and stained for this protein, this hormone-sensitive lipase, HSL. HSL is the enzyme that's important for lipolysis, that's going to generate the free fatty acids that are going to get released into the blood. And when it's activated to perform lipolysis, it's phosphorylated. So what you can see here in the left is the phospho-HSL, and this is the total HSL. So these are high-fat fed animals subjected to a stroke. 1 hour after the onset of ischemia, they're given a bolus of VEGF-b inhibitor. And then 5 hours after the stroke, they're given thrombolytic treatment with TPA. And then 30 minutes later, the animals are sacrificed and stained for phospho-HSL or total HSL. And I think you can appreciate here that indeed administration of thrombolytic TPA to treat the stroke is actually increasing lipolysis in the adipose tissue. If you compare this to this, the quantitation is over here, and that is normalized by treatment with a VEGF-b inhibitor. Okay, so that's in the context of stroke. So what about just giving the animals a bolus of TPA? What if you take a healthy animal, high-fat fed, of course, give them a bolus of TPA as you would to treat the stroke, and then look at what happens. And indeed, what you see by giving them a shot of TPA, you get an increase in the phosphorylation of HSL, indicating ongoing lipolysis, and that is quantified here. We can actually also look at this ex vivo. So in this experiment, the animals, these are high-fat fed animals that were given either a TPA bolus or no TPA bolus, and or a positive control. This is a beta agonist that activates lipolysis, known to activate lipolysis in the animals. It's just a positive control for the maximum amount of lipolysis. If you just give these animals a shot of TPA, and then 30 minutes later you take the adipose tissue out of the animal and put it into a dish and let it sit there for an hour and look at the amount of free fatty acids that are being released by that adipose, what you see is a doubling of the amount of free fatty acids that are being released by the adipose ex vivo. Okay, so no stroke, just a shot of TPA, take the fat out and look at it, and sure enough, you get the lipolysis activated. We see no change in systemic triglycerides in these animals, but we do see with a shot of TPA a significant increase in systemic non-esterified free fatty acids. And then we also see a significant increase in the brain. So this is systemic. This is in the blood. This is looking in the brain. In these animals that have just gotten TPA, no stroke, we see a significant increase in lipid droplet uptake by the endothelial cells in these mice. So is it really systemic or is it local? Because we know it could be both, but the data is sort of suggesting that it's systemic. So to answer that question, our colleagues in Stockholm made a conditional knockout of VEGF-b. So these mice have, the VEGF-b is floxed. They crossed it with an adiponectin Cree, which is a liver-specific Cree. And this is just a heterozygous conditional knockout. So we've taken out one allele in the fat, and that's it. That's the only reduction in VEGF-b that you see. And then we've done, compared the chow and the high-fat fed animals, performed a stroke, and looked at what happens 72 hours later. even in the lean animals, when you take out one allele from the fat of VEGF-b, you get significantly smaller infarcts. Not significant, but apparent reduction in spontaneous hemorrhage. And in the high-fat fed animals, you see, again, normalization of the infarct size significantly reduced, and a large reduction in the cerebral hemorrhage that's associated with this. So this is great. This is where we were a number of years ago when we were waiting to try and publish the story. And we were missing one thing, which was, is this really possible in humans? So I spoke to our ER folks and said, could we get some pre and post bleeds from patients who are receiving thrombolysis? And there was a lot of reluctance because obviously stroke, time is brain. You got to get them in, you got to get them treated. Getting them consented to draw blood for a study was just something that they were not interested in doing. So I'm sitting at the Gordon conference, and Rob, our cheerless leader here, gets up and starts presenting this talk where he says, we've been looking at TPA resistance, and I have 400 patient samples from pre-TPA and post-TPA. And I about fell off my chair. So, as soon as Rob got done talking, I grabbed him and said, can we look at those? And here's the results of that. So these are ischemic stroke patients who receive thrombolysis in less than 4.5 hours, and they have a pre and a post bleed, and we measure the non-esterified free fatty acids in those patients. And what you see here is a very significant rise in the human patients receiving TPA with in the post bleed. This is not just the result of time, because remember the post-bleed is obviously later, because if you just look at the time, there is a non-significant, modest increase in the non-esterified free fatty acids in these patients without thrombolysis. And then if you look at the triglycerides, you actually see the opposite. Triglycerides actually seem to be going down a little bit in these patients. So this seems to be a very specific response to TPA. So, what conclusions can we draw from this? We believe that metabolic dysregulation increases ischemic stroke severity, in part at least, by raising free fatty acids in the blood. Fatty acid uptake by brain endothelial cells reduces glucose uptake and utilization and increases cerebrovascular dysfunction. We see that in cell culture, and we see that in the animals as well. Thrombolytic TPA increases adipose lipolysis and plasma non-esterified free fatty acid levels in a VEGF-b dependent manner. And this is increasing, we believe, the endothelial cell lipid intoxication. And we like to think of that as lipid intoxication because the endothelial cells want to use glucose. But they're taking up the fat and they're switching their metabolism to that. And that's resulting in vascular dysfunction. We suggest, again, that this TPA-mediated intoxication is increasing the vascular dysfunction, and it may be a primary factor limiting the safety and efficacy of thrombolysis. Maybe if you could overcome this problem, you could make thrombolysis safe out to 24 hours, just like you can with thrombectomy. We found that acute inhibition of VEGF-b improves stroke outcome, especially in backgrounds of metabolic dysregulation, and that in human stroke patients, thrombolytic TPA raises the non-esterified fatty acids, suggesting that VEGF-b inhibition may be an effective adjuvant treatment for stroke. So this has been a really incredible collaborative study from 3 different continents. These are the folks who did it. Josu, stroke expert, Ulf and his gang in Stockholm, Richard Keep, who helped us with the electron microscopy. Couldn't have done it without Rob, and Rob's collaborator in Hungary, Zsuzsa, who actually collected the patient samples that we used. And then, of course, couldn't do it without the folks in the lab.